Thank you very much for the very nice introduction. First, I'd like to send you some greetings from the island of Lindau in the Lake Constance between Germany, Switzerland and Austria. Here I'm working every day. I'm going to talk about the concepts behind the OsseSpeed profile implant. The first part of my talk, I'm going to talk about the results of a multi-center study in healed sloped crests. Afterwards, I'm going to talk about the immediate function results with our OsseSpeed profile implant. And finally, I'm going to present the brand new results of our studies around immediate implant placement in case of slight and severe recession type defects. The maintenance of bone and soft tissue around implants is the most important goal in implant dentistry. With this new implant design, we try to support the peri-implant structures perfectly for a long-term aesthetic, nice mucosal result. The alveolar process is a tooth-dependent tissue. When the tooth is removed, we are going to have resorption. And we have several studies in animals and human subjects who show us that we will have severe resorption at the lingual as well as the buccal aspect, especially in height and in width. So this animation shows a typical post-extraction bone resorption of the extraction site with a healed sloped crest. And now the question for the surgeon, where to place the implant. Place it at the facial bone level and put it 2 millimeters below the lingual bone level. Then we'll get some resorption at the lingual aspect. Or do we place it at the level of the lingual bone? Then we may have some titanium shining through the facial gingiva, and it may require some facial bone augmentation. Or we choose an implant which is perfectly for this sloped crest situation, like this OsseSpeed profile implant, like seen here in this tomography. In a multi-center study approach, starting in 2008, we proved the peri-implant marginal bone maintenance around those sloped implants. This is a typical situation where a first molar has been extracted by myself 3 months before. And we see the slight lingual bone resorption and the severe buccal bone resorption. Here you can see an example how a profile implant is correctly placed in this sloped crest, preventing bone augmentation, maintaining the lingual bone height, and with circumferential bone support. In the time from implant placement to the 4 months re-entry, we just lost 0.2 millimeters of marginal bone. Here you can see the delivery of the prosthetic restoration at 5 months, and you can see that the width of the peritoneal mucosa is really much reduced. But in the long-term follow-up, right now we have the 6 years follow-up, you can see an improved width of the keratinized mucosa, thicker mucosa, higher papillae. The cone beam tomography at 6 years shows us that we were able to support the peri-implant bony structures and keep a bone level at the level of the sloped implant shoulder. Overall, in the study with 65 implants, we were able to show to maintain the bone level at the level of the implant shoulder, interproximally as well as buccal and orally. The soft tissue results was not an isolated single case you have seen. Here you can see a series of cases. In all of my 15 cases, we have seen those enormous improvement of the peri-implant mucosa, as well as of the bone. We have seen from the time of delivery of the prosthetic restoration to the 1 year follow-up, a significant improvement in width of the keratinized mucosa around an implant. It's a little bit strange effect. Never seen this before. But the reason for that is not fully elucidated by now, but we think that the reconstruction of the pre-implant fiber complex described by Finis already in 1952 is the reason for, as well as the maintenance of the lingual bony matrix by the special implant design. The traditional treatment concepts advocate a 2 to 3 months consolidation of the extraction socket, an additional time frame of 3 to 6 months for the unloaded osseointegration and some time for the prosthetic restoration. So, the disadvantages of the staged implant insertion concept are the reduced quality of life, since the patient has to work for a long time with provisional prosthesis. And we have substantial biologic drawbacks by loss of bone and soft tissue. And finally, we end up with a compromised long-term aesthetic result. Today, an increasing number of patients demands highly aesthetic rehabilitation in a very short treatment time with minimal invasive protocols for single or multiple teeth replacements. The main advantages of immediate implant insertion and immediate restoration are the reduced treatment time with less number of sessions. By the less invasive treatment protocol, we prevent a removal prosthesis, and by the immediate under-contoured restoration, we support the hard and soft tissue structures circumferentially. The very first implant which addresses this issue especially was the Tübinger immediate implant with a sloped necked design for the immediate implant placement into extraction site already in 1976. The height difference between the interproximal, the oral and the facial bone is the major problem in the aesthetic zone. When placing a flat top implant down to the level of the facial bone, you will get very deep below the interproximal bone level. The profile implant addresses especially this issue, since you don't have to place your implant so deep and you can support the interproximal oral tissues better. We evaluated 184 cone beam tomographies for immediate implant placement. And we have seen there's a height difference between the oral and the facial bone of 1.8 millimeters. And we can say that there's an overall indication for sloped implants to be placed in extraction sites in 48% of the cases. In our study, we just had 21 implants in 16 patients, but all were treated exactly to the same concept. All were done flapless in the aesthetic zone of the maxilla. All were grafted with autogenous bone chips, no connective tissue grafts. All were immediately provisionalized, and every severe bone defect was included. Here, one typical case: the patient had a slight pain but persistent, had a facial bone defect, had a post-restoration situation following several years after an epiectomy. The tooth has to be removed. We aligned our implant strictly to the oral aspect and grafted facial defect with autogenous bone and made an under-contoured temporary restoration. You can see in the follow-up to 3.5 years that we have a tissue maturation in height and in thickness and a very high papillae. The cone beam shows that we were able to reconstruct by this flapless procedure without a membrane, just with autogenous bone chips, up to the level of the sloped implant shoulder. The interproximal bone level at 3 years shows us that we are nearly exactly at the level of the implant shoulder. Comparing the preoperative to the 3-year aesthetic result, we saw a significant improvement of the pink aesthetic score according to Fürhauser from 10.6 to 11.8. And we had a significant improvement of the thickness of the facial bony wall. By about 3 years by now, we use the newest generation of the OsseSpeed Profile EV implants with a unique internal connection. Depending on the dimension of the implant, we have different height differences between the buccal and the all aspect, between 1.3 and 1.7 millimeters. This case, this patient showed up 20 years after a horizontal root and crown fracture. You can see here the slight recession. The reason for the slight recession is the facial misposition of the tooth, and you can see the horizontal crack. We removed the tooth and aligned our implant strictly to the all aspect, getting some space on the buccal aspect for tissue regeneration. We placed our impression coping on top. Then we created a supraparietal tunnel in the buccal aspect according to Allen. We splinted our impression coping to our surgical guide, took some connective tissue harvested from the palate, and then we took the connective tissue into the tunnel, pushed it inside, then we make a cut in the ramus area to get some bone chips with a micro safe scraper and graft the facial defect with those chips. You can see by the under contour temporary restoration that we can increase the facial soft tissue level by about 2 millimeters. So initial situation from the coronal aspect, taking the implant to the palate, we get some space for tissue regeneration on the facial aspect and support the emergence profile by an Atlantis abutment. Initial situation, now with the Atlantis abutment and increased soft tissue height and the final restoration. The overview and the final result at 1 year. So, another case, this case showed up with a quite high lip line at the left side. You can see the initial situation, presenting with a 2 to 3 millimeters recession and the perforation of the facial bony lamella and the root. So the tooth has to be extracted. But how should we treat this case? Should we use a connective tissue graft or not? That issue we tried to answer with a retrospective study using 40 implants, where we grafted all our immediate implants with autogenous bone chips. In one half we grafted just with autogenous bone chips, the other half we grafted additionally with a connective tissue graft. All had a recession between 1 and 3 millimeters. All were immediately provisionalized. Since we know from the study from Lee that the angulation of the implant is pretty important for the facial thickness, our implants all were angulated to the all aspect. As we also know from our own studies, we have a significant impact of the angulation or facial angulation of the implant to the palatal plane on the tissue thickness at 4 millimeters. We measured this with an ultrasonic device. So in this study case, we extracted the tooth, cleansed the extraction site intensively, and then we placed our implant to the all aspect. And just by taking away the pressure, you get an increased tissue height on the facial aspect, and without using connective tissue graft, just with autogenous bone chips. At 6 weeks, we reached the level of the neighboring teeth. The final restoration was done with the zirconia abutment and then a zirconia crown, so you see the 1 year result. At 8 years, she received a new prosthetic restoration since the crown and neighboring teeth had some chipping. And you can now see at 8 years that even we did not use a connective tissue graft, we still have a very nice contour and height of the facial tissue. Another case, severe case, since she presented with a slight recession, loss of attached gingiva, and a vertical root crack, and a complete loss of the facial bone lamella. So we placed our implant immediately, reconstructed with autogenous bone, and you can see here the 1 year and the 5 year result. The soft tissue level increased, the papilla level increased, but at the 5 year follow-up you can see a slight loss of the volume of the alveolar contour and the buccal aspect. The cone beam shows us that we were able to reconstruct the bone up to the level of the implant shoulder. In this case, the central incisor was lost by peritonitis. He showed up with a 2 to 3 millimeters recession, and we extracted the tooth, placed the implant immediately, and reconstructed with bone with an additional connective tissue graft. And you can see here the full coverage of the recession type defect with a nice volume at a 1 year follow-up, as well as a nice reconstruction of the facial defect. So, the results of this study show that in the autogenous bone graft group, we have an increase of the reduction of the recession by about 0.5 millimeter. In the autogenous bone graft plus connective tissue graft group, we had a reduction of the recession by 1.7 millimeters. And in 39% of the cases, a complete coverage of the recession. So, what can we do? Those were all recessions by between 1 and 3 millimeters. But what can we do with recession between 3 and 6 millimeters? Is there still a possibility of immediate implant placement? In this case, we have 5 millimeters and a horizontal root crack, partial loss of the facial bony wall. We know from the study of Lee 2012, a small case series with 11 implants, upper incisors with immediate implant placement and reconstruction of the facial defect after raising a flap, a full thickness flap, and he used BioOs and BioGuide plus a connective tissue graft for a transgingival healing process, and he was able to reduce the recession by 1.7 millimeters. So we did a retrospective study in 10 patients, 12 implants, and we used the flapless concept you've seen already before, and I show you now in the video how we treat it. We make a tunnel at the facial aspect according to Allen, which is a little bit more extended when you like to move it more, the tissue complex more coronal. You have to extend your tunnel more to the lateral aspect. And finally, you graft again with autogenous bone chips the defect on the facial aspect. We put it into doxycycline in between, and we use pluggers from our endodontics, and we push away the connective tissue and place the bone graft between the implant surface and the connective tissue down to the defect under the microscope. Finally, we restore this case immediately with a temporary restoration, and you can see how the tissue matures. 2 weeks and 3 weeks, we reach the level of the neighboring tooth, and then we restored it finally with an Atlantis abutment, and you can see here the 3-year follow-up with a very nice soft tissue level and a facial contour which is perfectly supported. Why is it perfectly supported? Why? Since we were able to reconstruct the facial bone defect by about 80 millimeters vertically without raising a flap, without using a membrane, just by plugging autogenous bone chips down to the defect. Another case, central incisor with 5 millimeter recession and the 3-year follow-up. Another case, a canine with 6 millimeters recession and a 5-year follow-up. So, can we apply this technique also when we have multiple recessions neighboring to each other? So, you can imagine what is underneath there. The teeth were hopeless by insufficient epicoectomies, and we removed all the teeth and placed implants. And important is the right alignment, vertical as well as oral facially alignment. You don't have to place your implants too deep. You want to create a tissue height. So we reconstructed with a lot of autogenous bone chips without cutting any papilla. And from the coronal aspect at 4 months, you can see that we were able to reconstruct between the central and lateral incisors the situation where the papilla is lost and the connective, the attached mucosa was gone. And you can see initial situation once again, and now the created new tissue volume, and that's at the delivery of the crowns. And now you can see some weeks later we took another photo, and you can see what happens to the tissue interproximally between those implants. That's the reason why we put profile implants in there, to maintain the all-bony matrix for anchoring the fibers. And the long-term follow-up shows the maturation and stabilization at this level. So, the results of this study shows that we were able to reconstruct the bony defect vertically, and we can reduce the mucogingival recession by about 3.5 millimeters. So, but what sounds not too bad right now, but what are the future visions for our immediate provisionalization concepts? We would like to reduce our treatment time by preoperative planning. We would like to have a higher precision of implant alignment if possible. And we would like to reduce the costs for our patients by less necessary components and a shorter treatment time. But we don't want to lose our spontaneous treatment possibility, and we would like to reduce the number of abutment reconnections, and we would aim finally to one abutment one time. Since we think this might have an impact on success, on the bone maintenance, and maybe also on the aesthetics. So we know that by guided surgery we have a very high precision, and we know already from 1997 that when you subsequently reconnect your abutments, you are going to lose marginal bone. So here another case, how we treat maybe all our cases in future. This concept is called immediate smile, when you look for one abutment one time. We are starting with a pre-op examination of the clinical situation, followed by a cone beam tomography, revealing the severe external resorption, which not allows us to keep the tooth. We make a digital impression and merge those data of the cone beam tomography and the intraoral scan in the Implant software, which allows us to plan an implant and order a guide. When we have accepted the planning, we can transfer those data to Atlantis to design and order an abutment. When we have accepted this design of the abutment, we can get a core file which we can transfer to the milling center for the fabrication of temporary restoration. Preoperatively, we just have to check, do we have everything, the guide, the implants, the drills, the abutment, as well as the temporary crown. Then we can start and place our implant through this guide and align it perfectly, and then place our zirconia abutment, which is specially made for this situation. We screw it in, and hopefully it will stay there forever. One abutment, one time. And then we can graft with the final abutment in time with our connective tissue. We can graft with autogenous bone chips, and it's not necessary anymore to change a healing abutment or something. And finally, we can place our temporary restoration on top, and we don't have to wait for anything. So here's the results at 5 days, and 1 month you can see the nice healing, and at 1 year, very nice soft tissue around it. When you look at the treatment time, and you can see that and compare the conventional with the digital workflow, that the digital workflow is at least quicker, and at least it is cheaper. So, and the main disadvantages are that we have to choose at the time of implant placement already our final development. We cannot choose between an undercontoured and a fully anatomically abutment, but we have the major advantage of one abutment, one time. The concept base, what you have seen in the last 20 minutes, is based on minimal invasive extraction, the reconstruction of the functional fiber orientation, the immediate insertion of an implant in correct three-dimensional position, and the flapless and immediate reconstruction of hard and soft tissue defects, supported by an immediate provinalization. So basically, it's not only the right implant concept, the right implant design, it's a minimal invasive approach, and the precision and the maintenance, the preservation of blood supply, which guarantees us those results. Thank you very much for your kind attention.
Robert, come over here. Take a seat. You'll forgive us, Robert. We're running a little bit behind, so we'll take questions for you as part of the discussion session, I think. Lotta, I'm sure you have lots of questions from the audience, and I know that everyone in the room will agree that we've just seen some really outstanding work, so my congratulations for that. But I think we should move on to...
Yeah, we have a lot of questions from the audience, but I also have the third and last question for you. So the last question is like this. Astrotech Implant System EV has an implant assortment: straight, conical, sloped, short, narrow and wide, that provides versatility to meet the needs of each individual site. So what is the sloped implant called? Is it OsseoSpeed Profile EV? Is it Tyoblast EV or Sive EV?
We have the pleasure of two people on stage now. Allow me to introduce first, Lyndon Cooper. Lyndon was born in New York State and is now Associate Dean for Research at the College of Dentistry at the University of Illinois at Chicago, and loves lecturing and inspiring the next generation of geniuses. He is, like many other professionals, very passionate about his work, but when he's not digging his curious mind into the next level of innovation, he likes getting into a kayak and hanging out with his wife and two sons. Also on stage is Lee Culp. Lee is the CEO of Sculpture Studios, a dental laboratory, research and product development center for new and innovative digital dental technologies. The focus at Sculpture Studios is on applied applications for diagnostic, restorative, and surgical dentistry. Lee has been the recipient of too many awards to mention, including the Kenneth Rudd Award from the American Society of Prosthodontics and a Distinguished Dentistry Service Award. Lee is the inventor of many of the materials, products, and techniques used in dentistry today, and truly one of the most exciting and innovative lecturers in digital dentistry. Please give a very warm welcome to Lee Culp and Lyndon Cooper.